Hi, my name is Jordyn Mitchell,
And I'm Jessica Taylor.
and today we're going to discuss a journal article with you that we found very interesting. The title is Haloperidol versus second-generation antipsychotics in the long-term treatment of schizophrenia. So just as a background, schizophrenia is a mental disorder. It really affects the way people think and feel and behave. It's more chronic and severe, causing people to really lose a sense of reality. But understanding pharmacological treatment and how to handle episodes are really crucial to treatment. So the pharmacological treatment that they have is first generation and second generation antipsychotics. So your first generation antipsychotics are known as your serotonin dopamine antagonist and multi-acting receptor targeted antipsychotics. And then while second generation antipsychotics are dopamine partial agonist. So in this article, they referenced other trials previously. So there was an article that showed continuous pharmacological treatment of schizophrenia is far better than doing intermittent treatment for schizophrenia for relapses. And then that was in 1996. And then also in 2013, there was a meta-analysis that showed the same results. There was another article that based on pharmacodynamics that the second generation antipsychotics should be more effective in preventing recurrences than haloperidol because of their broad spectrum activity and consequent activity on the different clinical dimensions of schizophrenia. There was also another study that showed haloperidol is better in terms of increasing positive symptoms, but that it can also worsen motor or negative symptoms. So really, this study was conducted because they wanted to replicate previous data to compare haloperidol to two second generation antipsychotics about the time of discontinuation in long-term treatment in a bigger sample size of patients. So this article took place at the University of Milan in Italy and also the University Medical Center of Utrecht in the Netherlands. They received no funding sources for this article. And the trial design was 220 schizophrenia patients treated with antipsychotic monotherapies, haloperidol, clozapine, risperidone, olanzapine, quetiapine, and aripiprazole at outpatient clinics in those two universities. A survival analysis was performed of the 36-month follow-up period to compare the single treatment groups. So our objective was, the purpose of this study was to compare antipsychotic monotherapies in terms of time to discontinuation in a sample of schizophrenia patients followed up for 36 months. So what they did was they took patients that were treated and followed up at these universities between the years of 1997 and 2013. All patients had a diagnosis of schizophrenia, and they were diagnosed based off the DSM-IV-TR. Also, other inclusion factors were oral antipsychotic monotherapy and had been in clinical remission for at least 1 month, according to Andreassen's criteria. So the exclusion criteria were patients who were treated with concomitant psychotropic medications. The only exception to this was the occasional use of benzos for sleep disorders. With medical therapies that could interfere with overall psychopathology was one exclusion criteria, and also patients who were treated with antipsychotic depot medications. Also, other patients that were using mood stabilizers or antidepressants were excluded in hopes to limit confounding factors.
Okay, so I'm going to talk to you about the intervention and experimental design. So the patients were divided into groups according to their oral antipsychotic monotherapy. These were haloperidol, clozapine, risperidone, olanzapine, quetiapine, and aripiprazole. The demographic and clinical variables were compared between treatment groups using a chi-square test for dichotomous variables or multivariate analysis for variance for continuous variables. In case of statistically significant differences between groups or potential confounders, they use a Cox regression analysis. This is used to detect factors which might influence time to recurrence. They used the mean haloperidol equivalent dose between the groups of drugs. So the outcome measures, this is the endpoint, was considered discontinuation for treatment for reoccurrence, side effects, or noncompliance. And the statistical analysis, due to small sample sizes, a few patients from the studies were excluded from survival analysis for the small sample size of potential subgroups. 2 patients from Milan, 3 from Utrecht were excluded from that. The Cox regression analysis that were performed on several of the test subjects that were topics of concern. This was the influence of the age and the continuation of treatment. We found that this was not predicted to be of treatment discontinuation. The duration of illness was no indication that there was a duration of influence that would play a factor in treatment continuation. A post hoc showed statistically significance between haloperidol and the quetiapine groups. Haloperidol equivalent doses, these doses were not found to be predictive of treatment continuation. Gender distribution, there was no indication that the patient's gender had any prediction on treatment continuation. Some study limitations of the study was the fact that it was lack of randomization, lack of first-generation antipsychotic overviews, different drugs having different doses, the groups being homogeneous in number, patient outcomes being treated in monotherapy versus chronic patients with polytherapies, limited comparison between the clinical variables. Survival rates could have been influenced by patients being from different centuries.
So enrollment, like I said, we went from 1997 to 2013. So overall, there was 459 patients from Utrecht and then 212 patients from Milan. But then after the exclusion criteria, the total sample included 220 patients, 137 men, and 83 women, and the mean age was 31 and a half. So also some baseline characteristics. So the duration of untreated psychosis was about 1.2. The duration of illness was about 7. Most of the patients recorded no substance abuse, about 73%. Most of them did not abuse cannabis, about 73%. Most of them didn't abuse alcohol. The most common reasons for discontinuation was non-discontinuation. And then the second top reason was inefficacy or reoccurrences. Side effects, the most seen side effect was weight gain, but only at 13%.
Okay, so the study findings or efficacy outcomes. So we saw that there was no statistical significant difference between the duration of untreated psychosis, the baseline PANS total scores, which the PAN is the positive and negative syndrome scale. This rates different treatments under positive and negative according to the schizophrenia on 7-point scales. There was no difference between the cannabis misuse, the substance misuse, or the alcohol misuse. So lifetime cannabis, cocaine, and alcohol misuses were not found to be predictive of treatment discontinuation. However, statistically significant differences were age, duration of the illness, the mean haloperidol equivalent doses, gender distribution, reason for discontinuation, and types of side effects. So in the Milan study, we saw that haloperidol and risperidone was used more frequently, to whereas in the Utrecht, we saw clozapine and quetiapine used more frequently. While there is no difference in frequency of prescriptions between the two sites, there were found for epomeprazole and olanzapine. So gender distribution, females were more frequently treated with the haloperidol over risperidone, olanzapine, or clozapine. In patient discontinuation, lack of efficacy was the more frequent reason to discontinue the medication in the haloperidol group over the olanzapine group. There was no statistically significant difference between treatment groups when level of compliance were collected. So we looked at survival rates between the antipsychotic groups. So our highest survival rate was clozapine, and they had a mean survival of 27.5 months, to whereas haloperidol had a survival of 11.25 months of mean survival. And then our adverse events were that 75.9% of the subjects did not experience any side effects, and the more apparent adverse reactions were weight gain being the most common, extrapyramidal symptoms, sedation, and diabetes.
Schizophrenia treatment is hard to maintain because of the variables being different in the patients with this disease. So this depends on the patient's criteria, effectiveness of the treatment, patient compliance, and the side effects that are experienced from the medications given. So schizophrenia is really hard to treat because of adherence. So it seemed that patients with atypical antipsychotics tended to maintain pharmacotherapy longer than patients treated with haloperidol. This study extensively supports this. The study, in parallel to other studies, showed that haloperidol treatment resulted to be often associated with EPS and olanzapine with weight gain. So there was no difference between the two treatment groups on discontinuation because of the side effects. The results should be interpreted with caution due to potential confounding factors.
So our professional opinion and reflection of the journal article is that we saw that there were some significant differences between the groups, and some that there was no significant differences between the groups. Some of the significances that we saw between the groups was the patient's age, duration of illness, patient's gender, side effects that were experienced. Some non-significant differences were drug and alcohol misuse, the PANS, and the DUP. Interestingly, weight gain was seen the most as a side effect in the antipsychotics, which could lead to females on the medications discontinuing these antipsychotics because of this factor. The atypical antipsychotics were within a smaller percentage of each other when it came to survival rates. However, haloperidol was seen to have the lowest survival rate of the antipsychotics studied, which earlier we saw that it could be due to different centuries between the patients too of age. And then haloperidol was seen to have, haloperidol's survival rate was significantly lower than the atypical antipsychotics.
Yeah, and also the study talked about haloperidol. There could have been an economic crisis during here, and a lot of the government funding doesn't spend a lot of money on mental health. So being prescribed haloperidol could be a reason for that too, because haloperidol is cheaper than the second generation antipsychotics, which in this case is interesting because they're having to watch the needs of their patients but it certainly would increase compliance and adherence to patients not being able to afford their medications. So overall, I believe this article was super interesting to us, and I believe it will help us in our practice as pharmacists in the future. Thank you.
The end. Thank you. Bye.